So before I get started, just a little bit about who I am and what credentials do I have to give such a talk. I run the Parkinson's Disease and Movement Disorder Center at Scripps Clinic, and we have a team, multi-specialty team, that specializes in deep brain stimulation. How does deep brain stimulation work? Some of you may have had deep brain stimulation, some of you don't, so I'm going to kind of keep this talk basic. Deep brain stimulation involves the placement of two leads in the brain, usually two, sometimes just one, targeting either two nuclei called the globus pallidus or the subthalamic nucleus. We usually do subthalamic nucleus. And then we deliver a current into the brain, sort of like a cardiac pacemaker, that's thought to modulate the way these cells communicate and enhance talk or chatter, as I like to call it these days. So what is happening? I think you all know about Parkinson's. What's happening in the Parkinson's brain? Well, deep within the brain, there's a set of nuclei, collection of cells called the basal ganglia. This basal ganglia helps communicate with other parts of the brain, which enables you to have fluid movement, or at least not as ratchety a movement as Parkinson's patients have. Within that ganglia is a little tiny area called the substantia nigra, which delivers dopamine to the other basal ganglia cells. Without dopamine, it's really difficult to make all those communications between the cells work, which results in the abnormal movement, such as tremor in Parkinson's disease, or the lack of movement, such as rigidity, bradykinesia, gait instability, that sort of thing. So what do the medications that we give you actually do to the Parkinsonian brain? Well, similarly, just like the substantia nigra delivers dopamine, we give you dopamine from outside in the form of medication. And for a while, what's called the honeymoon period in Parkinson's disease, it turns the basal ganglia back on, and it's almost as though you don't have Parkinson's disease at all. This honeymoon period is really nice for Parkinson's patients, but unfortunately, after about 5 years or so, the medications don't work as well, or they cease to work altogether after a few years. And this is the point where we generally like to do deep brain stimulation. So let's go over just a little animated model of how deep brain stimulation leads are placed. Again, we target a little nucleus called the subthalamic nucleus, which is right there. It'll light up in a minute. It's just below the other nuclei in the basal ganglia, but as you can tell, it's deep in the brain. Then a surgeon will put a little burr hole, either on one side or both sides, tunnel these electrodes through, which are about the size of an angel hair pasta. Each one has 4 electrodes on it, and with them we're able to stimulate that nucleus. And again, not through mechanisms of dopamine necessarily, but electricity itself enhance the communication between those cells. Then the leads are implanted under the neck. Unlike this cartoon, it really doesn't go through your face. It goes behind your ear, and we implant a generator in the chest wall. And through that generator, your neurologist or whoever does the programming, hopefully an expert in programming, can turn the thing on, deliver a certain amount of current at a certain frequency, and manipulate those 4 electrodes in an optimal way for treatment. So just in case you thought that all Parkinson's disease DBS patients are a computerized model of a well-buffed bald guy, this is just to show you that it's actually real people getting this procedure in a real operating room. And yes, there's sometimes a little bit of gore. But for the most part, this is considered a procedure, not so much as a surgery. And the risk for this type of procedure is actually quite low, and I'll go over that a little bit with you. So testing, how do we know where we are in the operating room? Well, one is we look at your tremor, which is why we have you awake, but with light sedation. And as you can see, this patient is undergoing deep brain stimulation, but hasn't yet had their electrodes turned on. Now, he's had the correctly positioned lead, and see how much better his tremor is when he's holding that cup. And whereas his writing was illegible before, he's now able to write without difficulty. So in part, we know where to go because of you. And that's why we keep you awake during that part of the procedure, but most people get to go to sleep when they're putting the lead into your chest. So what can DBS do? Well, it can treat all of the cardinal symptoms of Parkinson's disease, cardinal being rigidity, tremor, the slowness of movement, sometimes the postural instability or the balance problems. We like to say that deep brain stimulation can make you feel like your best day on your medicines, and yet it can be without medicines at all. It can improve your on time without that wiggles, and it can reduce your off time, and it can reduce that fluctuation between on and off periods. It can allow your doctor to lower or even discontinue your medications, and it often improves walking. It might improve the type of freezing that patients get, that can't get started or get frozen and can't unfreeze. And it usually buys you, people always want to know how long does it last. Well, the device lasts forever, but in terms of clinical response, it often just gives you back at least 5 to 10 years, and that's significant. What DBS usually cannot do, and a general rule, and there have been some studies to refute this, but the general rule is if Parkinson's disease drugs don't help the symptoms you're trying to control, DBS is probably not going to either. It often does not help speech or voice. Unfortunately, sometimes it makes speech and voice worse. So don't be going after DBS if that's the problem you're going after most. We don't know exactly what it does with mood or depression. Some studies at Scripps Clinic have shown that it actually elevates mood and it elevates positivity. We think it could help with depression, and we wonder if it might induce a little bit of impulsivity. So we're looking into that with our research. Cognitive function, don't go for DBS if you're thinking it's going to improve memory or cognitive function. It doesn't. But indirectly it might, because we're able to reduce your medicines, and sometimes it's the medicines themselves that are producing the cognitive dysfunction. And just know that DBS is not a cure. It's a treatment, but it's not a cure. What are the risks of DBS? Well, it depends on the center. If you have a good center which does careful patient selection and an experienced neurosurgeon who has a good track record, your risk can be something on the order of 1% instead of the 5%. But in that 5%, the major risks are bleeding, seizures, stroke, infection. Sometimes it can worsen speech or cognition, which is the reason that most implant centers do preoperative screening for that. There's always the problem with device malfunction, but you should know that most of these complications are reversible or at least treatable. Who are the best candidates for deep brain stimulation? Well, I can tell you our Scripps Clinic Movement Disorder Center criteria. We choose mid-stage Parkinson's disease. That depends on you, how many years you've had it. And we usually like to go with people that are just beginning to develop that wearing off of the medicine. We insist that they have a good response to Parkinson's disease medications. And the reason we do that is because we feel that if they don't respond to the medicines, they may not likely respond to the surgery. You cannot have the so-called atypical Parkinsonism like progressive supranuclear palsy. I don't know if you've ever heard of any of these, but the ones that do not respond to the medications are not good candidates. We don't allow anyone in with dementia. We feel that by the time you do deep brain stimulation, Parkinson's disease should be at least to some extent interfering with your activities of daily living. We do not take wheelchair-bound people because it doesn't really bounce you out of a wheelchair and set you back on the golf course like some of the things you've seen on TV might suggest. It's really not a last resort option. And the patient has to have a commitment to wellness and ability to participate in programming because it is quite an intensive experience. The National Parkinson's Foundation guidelines, if you're considering DBS, is to consult with a PD neurologist, usually a fellowship trained. Do your homework, check credentials, don't be afraid to ask. Choose an implant center which has an interdisciplinary team that has with great expertise in DBS approach. Hopefully not someone that just sits around the OR watching you while you're sitting on the table. Be prepared to invest in time for the pre-op and post-operative appointments like the screening for dementia, the screening for voice and speech evaluation. And that said, I'm going to move on to our panel to go over patient experiences. We've got Mr. Phinney here, and we have Morgan and Donna, who are two of my patients. All three have undergone deep brain stimulation. And I'm going to prompt some of these questions, but I'm going to invite you to ask questions as well at the end. So, Mr. Phinney, I might just ask you, what prompted you to seek deep brain stimulation?
Well, I had been aware of deep brain stimulation for several years and had run into a neurosurgeon through our work with the foundation, I don't know, 4 or 5 years ago, named Jamie Henderson up in Palo Alto. And just through the conversations and whatnot, I felt very comfortable that if I was going to choose DBS, that he would be a good surgeon for me. He was a cyclist, young guy, plays in the rock band with his kids and stuff, and just great sensibility and whatnot. And then subsequent to that, I was just becoming more frustrated and a little bit desperate with my ups and downs with the with Cinemet and whatnot. Not that it didn't work; it was just really difficult for me to manage my day, I guess I would say.
So you were having motor fluctuations already. Okay.
Yeah, and I mean, I had the surgery almost 3 years ago, and that was 7 years after diagnosis.
Okay.
So
it sounds like you met those candidacy requirements.
yeah. Yeah, and the wonderful aspect of my response, my personal response to the surgery, was evident even just on the operating room table, where you said, you know, how do you do your tests, and when my neurologist put a little juice into the electrodes, and had been off meds for the surgery for a while, so I was pretty uncomfortable, and and scrolling around, and it's just like all of a sudden I was just like, this incredible ease which I hadn't felt for so long, and that's when I knew I'd made the right decision.
Yeah. A lot of people report that in the operating room, that they're, just from the placement of the leads themselves, with or without the electricity being delivered, that they get immediate relief in their Parkinson's symptoms, and those are the people we know are going to probably respond best to programming. So, Morgan, what was the scariest part? And what was the most rewarding part?
I think the scariest part was the surgery, or the procedure rather itself. Having your skull open and having someone probe around with electrodes. I mean, that obviously is a rather daunting thought to have that happen. But I was so motivated for improvement that I was willing to take that risk. And like Dr. Hauser said, after I'd done a little bit of research, and I found that the problem rate was maybe 2% with the neurosurgeon that I was going to. I felt a lot more comfortable about that. But but once I got into the procedure, actually it wasn't bad at all. I mean, they gave me a mild sedative. I would recommend that you screen for your anesthesiologist and get someone with a sense of humor, because you'll spend a lot of time talking to him, and which I did, and a very enjoyable talk. I don't remember a whole lot of it at the moment, but then the most rewarding thing, I think, was like Mr. Phinney said, when they hit that sweet spot right in the right part of my brain with the electrode, my body just went calm. And it was the first time I'd felt like that in 7 or 8 years. And that was so encouraging. And then since then, I would say the best part has been everything. I mean, I feel like I've been reborn into a new life that, like Dr. Hauser said, I probably am back 7 or 10 years in terms of my symptoms, from where I was at the point that I had the procedure. So I don't really, it's all been good for me. I mean, I don't have any complaints, and I would really encourage anyone that is thinking about it to go talk to a few neurosurgeons and see what they have to say, and talk to people that have had the procedure, and make up your own mind. But boy, I'm a total evangelist for it.
And it should be stated that not everybody has this response. There are people out there that don't respond to deep brain stimulation. The reason we don't seem to see many of those in our practice is because we screen so heavily for these candidacy issues. So not everyone's experience is going to be the same, which is why it's a good idea to have a neurologist make sure you don't have the atypical Parkinsonian disorders. So Donna, let's hear from you. What did you like about your postoperative results?
Well, it was really life-changing for me. I'm a computer graphic artist, and I got to the point where I couldn't do what my passion was. And since the operation, I've been completely symptom-free and drug-free since April of last year. I kind of was forgetting to take my medication because my symptoms were so remote, and I just didn't feel them, so I took myself off the medication, and I've been drug-free too.
So do you think every day I've got Parkinson's disease, or does a day ever go by where you actually forget about it?
I don't think a day goes by that I don't appreciate where I'm at with it, but I certainly don't feel the symptoms anymore.
Can I add on to that?
Of course.
One of the best things that has happened to me post DBS is that exact aspect, because I would say there was not a minute that went by out of 24 hours pre-DBS where I wasn't reminded in some subtle way that I had the disease, and now hours go by without me even oh yeah, I have PT. You know, I mean, that in and of itself is really something. And the other thing I would say is that, you know, we had one of the doctors saying today that they felt that there was no research to say whether DBS was slowed your actual rate of progression. And I would say to that, if you have had a successful result from DBS, how could it not slow your rate of progression? Because we're not fighting our tremor all the time. We're not dyskinetic. Our sleep is much better. So just physically and functionally, that in and of itself has slowed my rate of progression.
Right, because it's not taxing the system as much.
Right.
Yeah. Well, you brought up a good point too about your sleep and the so-called non-motor symptoms of Parkinson's disease, like depression, mood changes, sexual function, sleep function. Did any of you feel that deep brain stimulation helped with the so-called non-motor symptoms?
I have a sleep disorder, and I sleep with CPAP, and the post-DBS, my sleep improved considerably. And I would say, as far as the other functions, I'd say probably across the boards everything has improved.
Okay.
And there's not a day I don't wake up and I'm thankful for having had the procedure, and that this technology is available to us today. 20 years ago, I probably wouldn't have been able to have it, and today, you know, it's available. And it's available to people with early stage or late stage, and fortunately, I had it done when I was fairly early stage. So.
Yeah, most DBS centers are doing patients earlier and earlier. It used to be thought of as sort of a later stage option, and it's sometimes difficult to make yourself proceed with any operation that has any risks when you're doing so well on the medications. And I can all understand that. It's not something uniformly people want to take that risk. Interestingly, I've found that men tend to take the risk a little bit more avidly than women. Therefore, we have a higher male population of deep brain stimulation patients in our practice. But Donna, did you have any female concerns about this?
Well, I remember seeing the procedure was highlighted in a segment on the Beijing Olympics. A father of one of the gymnasts had the procedure done, and I thought, that's what I want to do. So I actually came in with the intent of asking about it.
That's exactly what she said. She came in and she knew what she wanted, and she asked me for it, and she went straight for it. She didn't even mess around with the rest of it all. And Donna was not able to do her mouse, right? Which was interfering with your job, and now you're sort of back to your normal activities and off medicines. Although it's not the normal case that patients can go off of medicines altogether, but it's possible. And Morgan was surfing, and tell us how that changed.
It changed for the better. It's my sport that I'm really involved in, and I love to do it. I've surfed since I've been about 10 years old, which I won't tell you how many years that is in total. But it helped my strength. It helped my balance. It motivated me to get in better shape so I could continue to improve. And let's see, in about 10 days, I'm going down to mainland Mexico on a week surfing trip with my buddies. So it's been very good.
Mr. Phinney, you reported that you had sort of a fluctuating, one day you'd wake up, it seemed like it was going to be a good day, and then you'd have a fluctuating course. Do you think it smoothed that out to where most days are predictable?
Well, that's a good question. I also don't sleep great. I sleep much better, though, than I used to. And I really try my best to maintain a certain consistency, and I pay attention to what works well for me, how much rest or sleep that I need, how much. I find that if I exercise a little bit, not too much, but do something every day, that helps me sleep better, and so that's a plus. And so we were talking outside, and so I guess to amplify on those thoughts, the deep brain stimulation provides a constancy, which is 24/7. But we as humans don't work like that. And so it's as with learning how to manage your pill protocol, with deep brain, it's a matter of trying your best to just be consistent within any given day, so that you do have, when you have a good day or you have a great day, you can look back and say, oh gee, I did this, this, and this, and that then helps the whole. I don't know, does that make sense? It doesn't make sense to me. But
It helps the whole system.
yeah, something like that. I'm tired. I'm in. No, excuse me.
We can take maybe 2, 3, 15 questions. Okay, you raised your hand first.
What is the plan after that 5 to 10 year window?
Okay, so his question was that after that 5 to 10 year window, when the deep brain stimulation appears to not be working as well, and that's actually because the Parkinson's disease has progressed, what we're hoping for within that 5 to 10 years is we come up with something better. Medtronic, the company that's currently making the devices we use, is constantly working on a better device. In fact, they've manufactured a rechargeable generator. They've manufactured electrodes that have a pie-shaped wedge so we can stimulate different areas of the nucleus. And of course, there's research going on at all levels, at all times, about more curative processes. So what I hope for is that as we have a treatment with this electrical device, that other researchers are working on the cure, and if it'll buy you time to let us work, that's good enough for me.
I may be a unique person in this population, but I had the deep brain surgery and I had it removed. And I can tell you that in 1 week, they put the neurotransmitter, it was remote to me getting it implanted. And it worked. My legs especially were better coordinated. I was able to move about a lot easier, and I did feel that sudden relief in my head, I guess. But then I got a MRSA infection. They had to remove everything. So I've had an opportunity to be there and be back from it too. And I'm considering getting another operation. But I did notice, and my wife noticed, some decrease in my cognitive abilities. I don't know if that's shared amongst the population. You said something that it would increase.
Oh, definitely. It's that can occur, and that's why we caution, we pre-screen for subclinical memory and cognitive impairment, which doesn't necessarily mean you can't have the surgery, but the patient needs to be warned or appropriately have the wherewithal to take the risk anyway. But that's well reported in the deep brain stimulation literature, that it can impair cognition. But sometimes, as I said, it indirectly improves it by allowing reduction of medications.
Yeah, I was diagnosed within the last year with Parkinson's, and I'm taking the medications, and they've helped my motor skills and everything, but my tremor doesn't stop. So are you saying I'm not a candidate then if the medication didn't help my tremor?
No, especially where tremor is concerned, because a lot of the medications do not help tremor. Levodopa, even in high doses, sometimes does not help tremor, and that doesn't mean you're not a candidate. In fact, tremor predominant, Parkinson's disease, where the other symptoms may respond to the drugs but tremor doesn't, actually a very good candidate.
Yeah, because you're going to win that national tennis title at age 85.
My question concerns the rechargeable versus the non-rechargeable.
Yeah.
And I wonder if any of you have had the rechargeable implanted, and if you did, why did you choose that? None of you did. Why did you choose to go with the non-rechargeable?
They didn't have it available.
That's a good reason.
Yeah, they didn't have it available when I chose also, but I also would not go with it. Just because the recharge, depending on what your setting is still something that you have to remember to do every couple of days, maybe once a week or whatnot. And it just reminds me of the whole pill cycle, and I didn't want that. And with my battery, I have one battery that does both sides. And it's, I'm almost 3 years in. I asked my neurologist last time I had my settings tweaked, how much usage, and I was only about 20% after 3 years. And so, it's just one less thing to have to worry about and manage. And PD just gives you such a long laundry list of things that you got to remember to do, that one less is great. So that.
Most people choose to have the battery replaced every 6 years rather than have to be plugging their cell phone every night for an hour.
Yeah, well, and I don't even think it's that much.
It's
honestly.
not that much, but it seems like that much.
But I I think it's great that people have that alternative, and but it just wouldn't be for me even now.
Most of the rechargeable ones are for people with dystonia that have a really high voltage setting and they deplete their batteries really quickly. So it makes sense, that rather than have to have a battery every 2 years. But Parkinson's patients can go up to 6 to 7 years without a battery replacement.
Yeah, you indicated there were 2 places that the electrodes could be placed.
Two
What-
separate nuclei?
Right.
Uh-huh.
And what's the difference between the 2, and why do you choose one over the other?
Well,
Is it situational, or?
That's being determined when deep brain stimulation first began being used in Parkinson's disease, it was almost uniformly the globus pallidus, which is a big nucleus, easily hit, with the target. But research began to indicate that subthalamic nucleus might be better for what we call midline structures, like balance and voice, which didn't pan out, and other issues that didn't seem to be resolved with globus pallidus. Now the literature's sort of varying back and forth which one's better. I don't think either one is going to be better or worse, but it is more difficult to hit a tiny nucleus than the big one for the surgeon. Still, most centers throughout the United States and the UK are pretty much using STN more often until we have better literature. Well, we have to wrap it up, guys. Thank you for coming. I hope you've learned a little bit about it, just some food for thought. And I'd like to thank my panelists, and most of all, I'd like to thank Mr. Phinney for making this opportunity available for all these people in the Parkinson's community that wanted to hear your story and hear your philosophy. Thank you.
Thank you. Thank you all. Thanks, everyone, for coming.